Moving into some high-yield gastrointestinal pathology, we'll first start with GERD, gastroesophageal reflux disease, which is the failure of the lower esophageal sphincter to maintain adequate pressure, and then gastric acid reflux up into the esophagus. This is most commonly from just a transient lower esophageal sphincter relaxation, and then dealing with our vagovagal reflex from gastric distension from food going into our stomach. You can have hypotensive lower esophageal sphincters in conditions like obesity, pregnancy, hiatal hernia, and drugs, or there could be impaired esophageal acid clearance, but that is more rare. Common risk factors are, anything that's going to push up against the lower esophageal sphincter, so obesity, pregnancy, a sliding type of hiatal hernia, larger meals or lying down after eating. Also, things that increase acidity and decrease lower esophageal tone, so smoking, alcohol, coffee, caffeine, fatty foods, certain medications, and then a condition like scleroderma, which is a fibrosis of the smooth muscle, can lead to a loss of tone to the lower esophageal sphincter. Most time, clinically, patients will feel substernal burning, regurgitation that's worse after meals and when lying down. Um, Atypical symptoms could be a chronic cough or hoarseness, sometimes exacerbations in asthma or dental erosions or this globus sensation. Remember, we do not need to diagnose, so this is just tying in those diagnostic components to help you remember your clinical tie-in. This will be more helpful for NPLEX 2. Now, a progression here of chronic GERD could be Barrett's esophagus, and that could progress to esophageal adenocarcinoma. So we start here with normal squamous epithelium, and then in Barrett's esophagus, this is intestinal metaplasia. Remember, metaplasia is where we have one cell type transforms into a different cell type, and in intestinal metaplasia, we'll have goblet cells be there. So this is our metaplasia of our squamous. And then we see eventually that can lead to a low-grade dysplasia. Dysplasia is now where our cell types change from one type to another, and now those cells aren't all uniform and aren't all the same and are doing different functions. In low-grade dysplasia over time, that could lead to high-grade dysplasia, and if that persists, that can lead to an esophageal adenocarcinoma or cancer of the epithelial tissue. In metaplasia of our squamous cells, they transform into a columnar epithelium that kind of appears salmon colored, and that increases the risk of adenocarcinoma greatly. You do want to screen your AMAB individuals over 50 with chronic GERD for greater than 5 years. Um, Treatments listed below, again, I would ignore this for our basic science boards, but really recognizing this progression as a complication of GERD would be high yield. In peptic ulcer disease, this is an imbalance between mucosal defense and mucosal injury. We oftentimes see either an H. pylori-induced ulcer or an NSAID-induced ulcer. In H. pylori-induced ulcers, majority of them are duodenal, but you can still see gastric. In an NSAID-based ulcer, the majority are gastric. So H. pylori is a bacteria. It's gram-negative, meaning it'll stain pink on gram stain. It's spiral, it's microaerophilic, and it produces urease. It's able to colonize and live in the gastric antrum area of the stomach, and urease creates, a really basic base, NH3, which is alkaline, and that creates a little alkaline bubble that disrupts the mucosal layer of the stomach and protects the bacteria from the acidity of the stomach. So it's kind of creating its almost like force field around it. The antrum gets inflamed, which leads to a decrease in somatostatin, which leads into an increase in gastrin, an increase in acid, which can then later cause a duodenal ulcer as a complication. Some virulence factors for H. pylori include CAGA, which is cytotoxin-associated gene A, and VACA, which is vacuolating cytotoxin. The CAGA strains have a higher increase of gastric adenocarcinoma and a malt lymphoma. Malt lymphoma, if you have H. pylori eradication, you'll get remission in about 80% of cases. So really, it's treating the infection. In an NSAID-induced ulcer, again, more commonly gastric, you'll see NSAIDs inhibit our COX-1, which is then going to decrease prostaglandin 2, which then decreases mucosis and bicarb secretion, which if we have decreased mucosal blood flow, that's going to impair repair of our mucosal layer of our stomach. And then we can see increased damage due to the acidity of the stomach. There also can be direct topical injury from aspirin if aspirin's the NSAID that's being taken because aspirin's really acidic. The risk increases with advanced age if a patient already has a risk or a history of peptic ulcer disease, the patient's on other medications like an anticoagulant, or if a patient's on high doses of NSAIDs long term. COX-2 selective inhibitors plus PPIs plus misoprostol can be gastroprotective. If we're going to compare and contrast a gastric versus duodenal ulcer, as this is high yield, you'll see the gastric ulcers in the lesser curvature more commonly or the antrum versus duodenals in the anterior wall of the duodenal bulb. Acidity you'll see in gastric ulcers normal or decreased due to mucosal barrier defects versus a duodenal ulcer you'll see an increase in acid due to excess gastrin or H. pylori. H. pylori is more commonly associated with duodenal over gastric. Pain with eating is worse with gastric. There could be fear of eating or weight loss versus decreased pain with eating because the food buffers the acid. There's more pain 2 to 3 hours after meals once that acidic chyme moves into the small intestine. Night pain is uncommon for gastric, but common for our duodenal ulcers because the patients will be woken up around 2 to 3 in the morning when their meal moves to their small intestine. All gastric ulcers have malignancy potential. Duodenal, it's more rare. If there was a posterior erosion through the abdominal wall, you could be looking at the splenic artery and then hemorrhage versus an anterior erosion, it's more perforation and free air. Versus for the duodenum, posterior erosion would be the gastroduodenal artery, which would be a massive bleed. This is high yield. So knowing that this is a less common location of the ulcer, but if it happened here and it eroded, that'd be really bad for your patient. Perforation anteriorly would be more like peritonitis. Some complications, hemorrhage would be the most common, some obstruction due to pyloric stenosis. You could see then projectile vomiting and alkalosis, a hypokalemia. Penetration, really posterior ulcer would be the most negative, and perforation, more anterior ulcer, free air, and that'd be surgery. Both bad, but posteriorly it would be potentially quickly life-threatening. Um, I wouldn't look at diagnosis or treatment, but I do want to call our attention to Zollinger-Ellison syndrome or ZES. A gastronoma is a gastrin secreting tumor, and it's usually in gastronoma triangle, which is in duodenum or pancreas. Some features include multiple recurrent refractory peptic ulcers with diarrhea associated with MEN1 conditions, where we have cancers of the pituitary, parathyroid, and pancreas. You'll have an elevated gastrin level in this condition, in ZES or a gastronoma. Moving to another compare and contrast, we need to know our inflammatory bowel diseases and be able to compare Crohn's disease with ulcerative colitis. Crohn's disease is located in any part of the gut, mouth to anus, but the most common location is the terminal ileum of the colon or and the colon, versus ulcerative colitis is confined to the colon only, always, and always involves the rectum, extending proximately continuously. Crohn's disease has skip lesions, it's discontinuous and transmural or full thickness inflammation, versus ulcerative colitis is continuous kind of lesions, but it's superficial, it's mucosal and submucosal only. Macroscopically, Crohn's disease looks cobblestone-like with creeping fat or a string sign, versus ulcerative colitis has pseudopolyps, a lead pipe colon due to the loss of haustra. Microscopy, a non-caseating granuloma could be formed, and these are pathognomonic for Crohn's disease, versus crypt abscesses, and mucosal only would be the kind of pathognomonic condition for an ulcerative colitis. Symptoms can look really similar, but you could see more right lower quadrant pain with Crohn's versus left with ulcerative, non-bloody diarrhea with Crohn's versus a bloody with ulcerative, and weight loss with Crohn's and none with ulcerative, diarrhea with Crohn's, tenesmus or urgency with ulcerative. Complications can include fistulas, abscesses, strictures, obstruction, and issues with fat and B12 absorption with Crohn's. And in ulcerative colitis, you could have toxic megacolon where your colon gets really large. You could see perforation and massive hemorrhage. There's an increased risk of colon cancer. There's more risk with ulcerative colitis. And for surgery or associated other conditions, you don't need to worry about that at this time. IBT can manifest elsewhere, and so it can cause joint pain in the larger joints, as well as ankylosing spondylitis or sacroiliitis. It could lead to erythema nodosum, which are tender red nodules on the shins, or pyoderma gangrenosum, which is more deep-seated ulcers. Uveitis is most common complication, but there's also episcleritis or conjunctivitis. And then primary sclerosing cholangitis is strongly associated with ulcerative colitis and an increased risk of cholangiocarcinoma. Lastly, anemia from iron deficiency or chronic disease can occur, hypercoagulability, and a DVT. When thinking about, well, how is this different from irritable bowel syndrome, which is a functional disorder? Irritable bowel syndrome has our Rome 4 criteria, which is abdominal pain associated with relief from defecation, change in stool frequency, and change in stool form. There's many different types of IBS. And of course, when you're working this up, you want to rule out your big beds and scaries. So your rectal bleeding, unintentional weight loss, waking up from patient from sleep with diarrhea, etc.